So secondary prevention in atherosclerosis vascular disease. Someone has a vascular disease, obviously they have more high risk in future. So aggressive management of modifiable risk factors, smoking, hypertension control, hypercholesterolemia treatment is crucial due to high absolute risk of recurrent vascular events. Statin therapy. All established coronary artery disease should receive statin therapy, regardless of cholesterol levels, whether they are high, low, medium, whatever, statins are there. Blood pressure control, target blood pressure control to less than 140 by 85. And in very high risk populations like kidney disease and diabetes mellitus, even lower. Aspirin and ACE inhibitors are beneficial in patients with vascular disease. Beta blockers are also better for MI and heart failure with reduced ejection fraction. It is usually very relevant that people are not apprehensive or not aware of their risks and their risk factors and all the primary and secondary prevention advices until they have an event. And when they have a myocardial infarction or surgery or some event, then they become responsive to lifestyle advice and smoking cessation advice. However, primary prevention should be tried at most, especially in those with high cholesterol levels and those with risk factors. And in secondary prevention, statin therapy will reduce all cause mortality, major adverse cardiac events, coronary revascularization, and stroke. Benefit is also linked to risk. If there is highest risk, there is more benefit. So when the patient is given statin, in patient without evidence of coronary artery disease but with high serum cholesterol concentration, cholesterol lowering with statin does not lower mortality but does prevent coronary events like angina and MI. In secondary prevention, if someone already has those problems like MI or angina, statins safely reduces 5-year incidence of all-cause death as well as major coronary events, revascularization, and stroke. Benefit depends upon the overall risk of study population, but number needed to treat for 5 years to prevent one death is from 10 to 90 people. We clicked this link given below, but it didn't yield anything. When ACE inhibitors, they are also beneficial in reducing risk of death, MI, and stroke in patients with atherosclerotic cardiovascular diseases without apparent LV dysfunction in systole or heart failure, and number needed to treat to avoid one event over 4 years range from 6 to 50, depending upon the level of cardiovascular risk. This is based on HOPE and Europa trial. When we should give aspirin? In those with established coronary artery disease, peripheral vascular disease, or thrombotic stroke, aspirin is effective in reducing morbidity and mortality, non-fatal MI, stroke, and cardiovascular death. In patients at high risk of future vascular events, the overall risk reduction is 22%. So everyone is not a candidate for aspirin. And this is the link for clinicalevidence.org. And this is the interface. You can see that you can browse clinical content for recent updates, different specialties, patient information, videos, calculators, etc. on BMJ best practice. And you should not prescribe aspirin or statins like water to anyone thinking that it prevents everything. They should be used with caution and with proper risk calculators in a individualized context for each patient. This is about secondary prevention. Thanks for listening.